Thanks to Professor Ikeda and Professor Ann-Lii for your kind introduction. Dear colleague, it is my great pleasure to join you in the Tokyo meeting of Apostle Oncology 2021. Today, I'm going to share with you some of the thought of integrating systemic therapy into multidisciplinary treatment of SCC. And I would like to address the increasing awareness of systemic therapy for SCC in Asia, how it is in reshaping our clinical trial and daily practice. In terms of clinical trial, as you can see here, 13 years ago, when Asia Pacific study was reported, the treatment arm of the sorafenib has a median overall survival of 6.5 months, compared with the 7.9 months of the placebo arm of SHARP. It is obvious that the Asian Pacific subpopulation has a worse prognosis 13 years ago. But change over time has been noticed. As you can see here, if we review all the sorafenib arm in the past 13 years, then you will see in year 2008, as I just mentioned in the AP study, the median overall survival was only 6.5 months. But in year 2013, in the sunitinib trial, it was 8.8. And in the Brevity trial, it was 8.9. And in year 2017, in the lenvatinib trial, it was 11 months. And in year 2019, in IMBRE 150, you can see that the median overall survival of sorafenib arm in Asia was 13.1 months, and it was 13.2 months. It was almost identical in the sorafenib arm for Asian versus non-Asian. And recently, if you notice in the Checkmate 459 or in the Cosmic 312, the median overall survival of sorafenib was increasing, and there's no difference between Asian and non-Asian. So we can see that 2008 through 2020, the median overall survival of the sorafenib arm in Asia improved from 6.5 months to 13 to 15 months. It was more than double. And the reason behind this, we are now using less exhausting tests, and therefore we enroll the patient earlier into the trial. So that was because of increasing awareness about the benefit of systemic therapy in this disease. In the lenvatinib trial, you can see that the Asian actually benefit more than the Western population. And same in the atezolizumab trial, the Asian subgroup benefit more than the rest of the world. So after 13 years, Asians are no longer a worse prognostic group in global trials of systemic therapy. And following the same trend, you may say there's a reshuffling of the cards. We have awareness of systemic therapy in Asia, and it's changing our practice in intermediate as well as advanced stage of SCC. In the intermediate stage of disease, more and more of the study are testing whether a concurrent systemic therapy and TACE will improve the result of TACE alone. And as pioneered by Dr. Kudo, that there is a changing paradigm of treatment strategy, particularly for those TACE unsuitable patients. And it was defined by primarily high tumor burden for those TACE unsuitable. And they will receive upfront systemic therapy first. And when they have a downstaging, the local regional therapy with curative intent will be tried. So it is systemic therapy first, and then local regional therapy for the intermediate stage of disease. And this is a pilot study, indirect propensity score comparison of lenvatinib first versus TACE first. And in this study, Dr. Kudo reported a 37.9 months median overall survival versus 21.3 for the TACE alone arm. And as expected, patients receiving lenvatinib first has enjoyed maintenance of liver function, while the TACE arm has a deteriorated function after severe TACE procedure. But in another study, the intermediate stage, not only by lenvatinib, but also by atezolizumab. And there is a so-called curative conversion rate by atezolizumab. And the conversion rate was estimated around 20 to 30%. And these are the patients that a curative attempt may be tried. The only problem is about the TACE unsuitable patient definition. So as we can notice, the beyond up to 7 criteria was adopted in Japan, but we know that in many other parts of the world, including many of the Asian Pacific region, that the criteria may not be the same. So TACE unsuitability criteria may be fine-tuned in the individual geographic region, depending on the local situation. And awareness of systemic therapy may have an even more profound impact on advanced stage disease. You may be wondering why it is that, because advanced has already should receive systemic, but it is not true. As reported by Dr. Park Jun-won from Korea, that almost 80% of the patients of BCLCC receive local regional therapy. And this is reported in Bridge study that incorporate 18,000 of real-world patients. So this is quite the real-world situation that many of the BCLCC patients actually receive local regional therapy. So we can see that there are a lot of debate whether we should do more aggressive procedure such as liver resection and versus non-surgical, primarily systemic. And this was just reported by Professor Kokuto, and showing unequivocally that a liver resection may do better than systemic therapy, even for those with vascular invasion of the intermediate stage of disease. But we know that systemic therapy, with the pass of time, the outcome may improve rapidly, and particularly in the recent few years. So this kind of argument in the future may not that important. And for example, in Dr. Kudo's report, that even in advanced stage of disease, there was a 13% of chance to have a curative conversion. So this in some ways saying that effective systemic therapy may be given earlier, and to ensure a curative resection is possible. But on the other hand, effective adjuvant systemic therapy will encourage resection of higher risk lesions. For example, for the ongoing 4 study of adjuvant immunotherapy after resection of liver cancer, all of them are resecting patients beyond BCLC resectability. And 2 of them are even resecting those with macrovascular invasion. So effective adjuvant will encourage resection, ablation of high-risk lesion. So in other ways, effective systemic therapy may be used upfront, so may ensure a curative conversion. Or in the other way, that can be used after a resection or high-risk lesion, and then to increase relapse-free survival. So overall, as a conclusion, in the past, probably 5 or 6 years ago, about 20% of the patients in the intermediate stage of disease, and about 20% of the patients with advanced stage of disease receive upfront systemic therapy. But with the pass of time, now more and more patients in the intermediate stage of disease, particularly those higher risk lesions, as mentioned by Professor Kudo. And in advanced stage of disease, more and more patients will receive upfront systemic therapy first and seeking a cure after curative conversion. So these patients can be divided into 3 major categories. That with upfront systemic therapy, either intermediate or advanced stage disease can be downstage to a stage that can be resected, ablated, or TACE. And they can receive concurrent systemic and TACE. And finally, aggressive OPRA may even be encouraged because they can be saved by adjuvant systemic therapy. So in summary, Asians are no longer worst prognostic group in global trial for systemic therapy. And we are trying to make the most out of effective systemic therapy, engage more patients with curative attack. And multi-modality approach incorporating systemic therapy from the beginning will become a trend. Thank you so much for your attention.